webinars for the presentation are Drs. Judith Cohen, Susana Rivera, and Dr. Leslie Ross. Dr. Judith Cohen is a board-certified child psychiatrist and medical director at the Allegheny General Hospital's Center for Traumatic Stress in Children and Adolescents in Pittsburgh, Pennsylvania. She's a co-developer of the trauma-focused cognitive behavioral therapy described in Treating Trauma and Traumatic Grief in Children and Adolescents. She is a consultant to the Sesame workshops, Talk, Listen, and Connect, and the Tragedy Assistance Program for Survivors. Dr. Cohen also serves as the co-chair for the National Center for Child Traumatic Stress Child Sexual Abuse Committee. Dr. Susana Rivera is a licensed professional counselor with extensive experience providing treatment for children and adolescents who have experienced child sexual abuse, traumatic grief, and other traumas. Dr. Rivera is also a trauma-focused cognitive behavioral therapy trainer and has been responsible for disseminating this model to clinicians across the state of Texas. In addition to child traumatic stress, her research interests include the effects of culture on provision and outcome of mental health treatment for Hispanic children and families. Dr. Rivera is a program director for the Border Traumatic Stress Response Center at Serving Children and Adolescents in Need, Incorporated. And it also serves as an adjunct professor at Texas A&M International University in Laredo. Dr. Rivera also serves as a co-chair for the National Child Traumatic Stress Network's Child Sexual Abuse Committee and is a member of the NCTSI Evaluation Steering Committee. Dr. Leslie Ross is currently the Vice President of the Leadership Center at Children's Institute, Inc. in Los Angeles, where she oversees programs in research, program evaluation, training, and implementation of evidence-based practices for the treatment of child trauma, family violence, and child abuse. She's the program director of the Child Trauma Center, a participating site in the National Child Traumatic Stress Network, and serves as the co-chair for the Secondary Traumatic Stress Collaborative Group. She is also part of the NCTSN Task Force for the Core Curriculum for Child Trauma. She's a co-author for Responding to Domestic Violence, the Whole Person Approach, group treatment model for adult victims and their children. She's also a member of the clinical faculty at UCLA Geffen School of Medicine. Dr. Ross, would you like to share a bit about the Secondary Traumatic Stress Collaborative Group?
Yes, thank you so much, Kimberly. I wanted to say a few words about what we are doing with the Secondary Traumatic Stress Collaborative Group for NCTSN. This group was originally started as a subgroup under the Child Welfare Committee, but in the last year we've realized that the need is very important as we move more and more towards implementing evidence-based practice and increasing the risk to providers for being exposed to secondary traumatic stress. So we wanted to really take the lead in beginning to develop more materials, more resources, and more research around this area. This webinar is our first webinar that we are launching in this area, and our hope is to continue to do other webinars in collaboration with other national collaborative groups on other related topics. And so I'm very excited to have the opportunity to be participating in this initial webinar and look forward to continuing to work with other collaborative groups on additional ones. Thank you, Kimberly.
Thank you so much. Our first presenter will be Dr. Judith Cohen. Dr. Cohen?
Thank you, Kimberly, and thank you, Leslie. On behalf of the Child Sexual Abuse Committee, we'd like to welcome everybody and thank Leslie and the Secondary Traumatic Stress Work Group for inviting us to participate with them on this first webinar, the first of many, we hope. So could we have the next slide, please? So what is secondary traumatic stress, sometimes called vicarious trauma? Excuse me. It's often defined as when one individual experiences traumatic stress secondary to a second individual's traumatic experience. For example, one that was experienced by a client. So the first individual who's experiencing the traumatic stress symptoms secondary to the second individual's experience may have classic PTSD symptoms, such as thoughts or dreams about the trauma that was experienced by the other person. They may have avoidance of reminders, things that remind them of the traumatic experience that the other person experienced. they may have increased arousal symptoms like difficulty sleeping, jumpiness, irritability, and other physical symptoms, which I didn't list here, but certainly physical signs and symptoms are a hallmark of secondary traumatic stress. But as we know with children, trauma symptoms may not fall under the classic PTSD diagnostic criteria. An individual suffering from secondary traumatic stress may have anger, may have depression, may have cognitive difficulties such as trouble concentrating, and a whole variety of other kinds of difficulties. They may not want to go to work, or they may work too hard. They may become a workaholic. So secondary traumatic stress may manifest itself in a whole variety of ways, aches and pains, headaches, stomach aches, and so forth. So again, just like in children, we may see a whole variety of difficulties. Next slide, please. It may impact a mental health professional's view of the world. So an altered view of the world. The individual suffering from secondary traumatic stress may feel like they're more fragile or vulnerable and that the world is more dangerous. And that can lead the person to make more choices, for example, to be more averse to taking risks. And I knew of one individual who was afraid of taking new clients because every client this individual saw as a potential risk for suing the person because everybody seemed dangerous. Everybody seemed like, I'm afraid that if I take this client, I might be vulnerable to getting sued. For no reason, this therapist had never been sued but was afraid that she might be. Professionally, therapists who are suffering from secondary traumatic stress may become avoidant of things that they think may put them at more risk or may put them more in the highlights of or more at risk for being exposed to more trauma or what they see as having more trauma exposure. For example, being promoted to a more responsible position, or perhaps learning new evidence-based practices such as trauma-focused treatments where they may hear more direct trauma material. And they may be impacted personally. For example, they may avoid relationships, they may avoid activities or travel. For example, I knew somebody who used to be quite adventurous, want to go on every new trip, every new adventure, go skydiving, go deep-sea diving, and now this person does not want to be in a new relationship because it's too risky, doesn't want to go on trips because she's afraid of what might happen, and so forth. So it can be quite impactful in terms of how you view the world and yourself in it. Next slide, please. Interpersonally, and I've experienced this myself earlier in my career, you may have negative impact of how you view others because of how you've seen that trauma can impact others and fearful of how this might impact you. So, for example, when I started working with a lot of children who had experienced sexual abuse and I heard all these stories, I started thinking, men aren't so nice. Men do a lot of bad things in the world, and they do a lot of bad things to children. And I can remember quite clearly coming home being quite angry at men and thinking, all the men in the world are basically jerks. And the man I was coming home to, I was thinking, you don't look that great yourself either, so just stay out of my way. And it was really leading me to having some difficulties in my intimate relationships. It can lead to impaired trust or cynicism, and in some cases leading to the use of inappropriate humor to deal with these feelings. We all know about the stories of how surgeons sometimes can refer to their patients as, the gallbladder over here, the liver over there. But we also know of mental health professionals who can sometimes refer to their clients in ways that distance themselves or even inappropriately, such as the cutter or the borderline, as rather than as a person who's having difficulty with affective or attachment instability. And that can be a way of dealing with these problems that the professional themselves is having with secondary traumatic when that's not funny anymore, and that's really an indication that something's going on. Next slide, please. Those of us who are parents might notice that secondary traumatic stress can impact how we interact with and see ourselves in the parenting role. So when we hear about the things that happen to children, when we're seeing children who have experienced sexual abuse, we may develop magnified fears about sexual abuse happening to our own children and the risks of that happening. Of course, there are risks. When we hear that 1 out of 4 girls and 1 out of 6 boys experiences sexual abuse, we know that it is a real thing that can happen to our children, but we can get extremely overprotective, overconcerned, intrusive about how much we educate our children, when we educate our children, and to what degree, what lengths we go to protect our children and educate our children about sexual abuse safety. We can get into conflicts with our spouses or partners about parenting, how we do this, and where we let our children go, how independent we let our children become, whether we're developmentally appropriate in this regard. If our own child experiences sexual abuse, which, as I said, is not that uncommon, we may experience extreme self-blame. Why didn't I protect my child? How could this have happened to me, of all people? Why didn't I prevent it? Why didn't I recognize the signs right away? And of course, we know that all parents go through this, but we may go through it to an inordinate extent or degree because, I'm a professional. This is what I do for a living. How could I not have seen the signs? How could I not have known? And we will blame ourselves to such a degree and such an extent that it will eat us apart and eat us alive if we're not careful. Next slide. For those of us who have a personal history of sexual abuse, the personal triggers and cues are frequent when we're working in an environment or working with clients who have a child's sexual abuse history. It may be extremely challenging to maintain appropriate professional boundaries and or to contain our own personal emotions. And the question often comes up, is it helpful or harmful to share our own personal sexual abuse history, and in what situations would it be harmful, helpful, appropriate to share such a history? It's certainly, under any circumstances, critical to know our own personal hot spots and triggers and how to manage these most effectively, and to recognize when we may not be, and what to do, how to care for ourselves when we're not dealing with them as effectively as we might wish. And it's really critical for us and everybody else to recognize that it's also a significant potential strength to have a personal sexual abuse or other trauma history when working with clients who have the same history. And how many times do we hear a parent say, I had this happen to me when I was a child, and this is the first time that anything good has come out of this. That this is, for once at last, I know how to help my child. And the first time, I can be thankful that this happened to me because nobody did for me what I feel I can do for my child now. So we really need to recognize what a strength and how healing it can be, that previous victims can contribute to the healing of others who have experienced this, and recognize it as a resilience and a source of strength, not just a potential vulnerability. Next slide. If you are a supervisor and not just a therapist, it's important to recognize that you may be hearing many, many cases related to sexual abuse, and you may be hearing these on an ongoing basis. And the effect on you and the potential for experiencing secondary traumatic stress may be magnified and multiplied. Not only because you're hearing so many more cases, so if each of the therapists that you're supervising has 25 or 30 cases, and most of those are clients who have experienced sexual abuse, and you're supervising 5 therapists, that number gets really high. That's about 100 cases. Not only is that difficult to just logistically keep track of what's going on with all of those clients, And some of those clients are complicated, and some of them have crises, and they're going to court and investigations and returning to see the perpetrator, and who knows what other kinds of difficulties and challenges and safety issues going on. But you have less direct contact. You have no direct contact typically, and very little control over what happens to these children and their families. And when there is a crisis or, heaven forbid, if something happens and the child is re-abused, you feel a huge heightened sense of responsibility, but very little control over what happened. And that magnifies your sense as a supervisor of helplessness and anxiety and responsibility for these children and their families, and heightens your worry if something goes wrong or if you missed something. You have great responsibility and very little control. And that's a great recipe for you to sit and worry and stew and think about what could go wrong. And that's really a setup for secondary traumatic stress, because you hear the details, and often the way supervision goes, you hear the worst of the worst cases, because you hear about situations that your therapists are most worried about, or the most have the highest acuity and the most potential for crisis, and not the cases that are going well, because those are the ones nobody's acutely worried about. And they come to you, and they're recounted to you at their highest acuity, and then all you have to do is worry and wonder what's going to happen from one week to the next. So that really is a setup for you developing secondary traumatic stress. So you need a strategy for managing the anxiety and the worry. And hopefully we'll give you some ideas about that. Next slide. How can we take care of ourselves? First, we have to recognize that self-care is a legitimate priority. And as was said in the Bible, physician and all of the rest of us heal ourselves, we really need to make it a priority. And we need to recognize that we can't provide optimal clinical care or supervision if we are traumatized ourselves, if we're suffering ourselves. That's the basis of what they say on the airplane, put your oxygen mask on yourself before you put it on somebody else. We always talk about parallel process, and if as a supervisor you're trying to help your therapists, and as therapists we're trying to help parents so they can help their kids, it just flows downhill. Each of us has to start with taking good care of ourselves before we can model, for the next person along the line how they can do it for the next person. So if we're not doing it for ourselves, it's do as I do, not do as I say. So if we're not taking care of ourselves, we can't expect organizations to prioritize this. And we also need to understand that administrators, and if you're therapists, supervisors, nobody can read our minds. This is, again, what we tell our clients, what we tell parents. We really want to achieve, give clients skills for self-actualization and give them mastery, and we need to get some mastery ourselves in advocating for ourselves. So we need to do this respectfully, but we do need to do it. Find our own voices about what do we need and how can we get it. Next slide, please. In order to do that, we have to recognize what organizations can do and what they can. So they probably cannot lower our overall caseload, and they probably are not going to get rid of paperwork anytime soon, because that's required to meet regulations. And they're probably not going to get rid of evidence-based practices. On the other hand, organizations really do want to serve traumatized individuals. And believe it or not, they do want their employees to be satisfied. They are not aiming for high turnover and high attrition of employees, because that just wastes their time and money. So organizations want satisfied employees. They don't want traumatized employees. They want us to be happy and fulfilled. So how can they balance all of these needs, and how can we help them do it? How can we help us, ourselves, to be fulfilled and satisfied? Next slide, please. Well, it starts with knowing ourselves. And again, this is a very old piece of advice, but it's not always easy to follow. Each of us has to recognize what are our personal stress triggers, and how can we keep those from turning into trauma triggers? What kinds of cases are hardest for you? What kinds of individual clients really push your buttons? And is it possible to limit the number of those kinds of clients or cases you have at one time? If it is, you're one of the lucky therapists. So if you can do that, then try to negotiate for that one change. Many therapists can't do that, so you need to work out some strategies for managing the times when you have a whole caseload of the most stressful kinds of cases. And that needs to be something that you work on with your supervisor or maybe yourself in therapy, as we'll talk about. But, you can't just say, there's nothing I can do, I'm helpless, I'm here, a victim, it keeps piling up and, it gets worse and worse and there's nothing I can do, because that is not a strategy. That's just helplessness. So if you recognize a stress trigger and it's piling up and you're helpless, that's not a strategy. You have to figure out something to do. Is there anything the organization can do to limit it? If the answer is no, then you have to figure out an alternative strategy. So saying, okay, this is the problem, meet with your supervisor and say, I need help figuring out a strategy to address it. And problem solve around it. Just as you would with a client who says, this is a situation, I can't get out of it, I need some skills to deal with it. You know what you would say to a client, you know what you would say to a parent. You and your supervisor need to get together and figure out, how can I deal with the situation? I can't get out of it, short of finding a new job, which, by the way, might be an option. How can I do it? Next slide. So here are some options. If you can, don't make your whole caseload full of child sexual abuse or trauma cases. If that's not an option, consider other opportunities. Mental health is a big field. There's research. You can do assessment. You can do teaching. The point is, you're never stuck. I had somebody come to me who said, this is really stressful. And I said, well, what are your other choices? There are other jobs you could take. And the person said, well, they don't pay as much as this. And I said, well, then that's a choice you're making. You're choosing, you want the high stress for the high pay. So that is a choice. Recognize what choice you're making and what the cost is of that choice, and that you could make a different choice. Next slide. Self-care for supervisors. So if you're one of those supervisors that's overseeing 80 or 100 cases, and they're all, high stressful cases, think about how you can simplify following these cases to figure out where are the different cases. So if some of them are using an evidence-based practice, the use of adherence checklists can help you track the cases and see where they are. And some of them might be at a relatively simpler place in treatment than others. So following where they are in treatment may be helpful. And following an adherence checklist may help you keep track and organize where they are. Working closely with therapists about how to prioritize which cases need your attention. Where are the high concerns? How can you anticipate that? How can the two of you work together to address high concern when the issues arise? Working together, you can decrease both of your worry and figure out a system for doing that. Explore the possibility of supervisory support groups to share the concerns you and other supervisors share, and also to obtain mutual support, because, as I said, supervisors are in a high-risk situation. And then exploring ways to obtain support from other levels, higher levels of administration. For example, getting a day a week or a day a month when supervisors do different tasks and they have some time off from this worry, or they obtain some other levels of support from administration. Next slide. And of course, taking care of ourselves, recognizing what else we need that doesn't come from work. Exercise, eating and drinking right, relationships, taking every minute of vacation we can. I'm guilty of not doing that. Knowing when it's time for a change, when work is just piling up. If you're one of those people who takes on more projects than you should, says yes when you should say no. Getting help when we need it. Whether it's professional help or asking for help from your colleagues, or, delegating responsibility when you're taking it all on yourself because you're one of those people who says it's easier to do it myself than to ask somebody else for help. Next slide. Asking for help, including from supervisors, peers, experts, or therapy. Your supervisor should be available to help. If you feel judged, there may be a problem. Peers, you should be able to ask informally for help. Asking for expert consultation, including asking your organization to make formal arrangements for case consultation if you're implementing an evidence-based practice. Finally, asking for therapy or getting therapy on an ongoing basis if you're feeling a high level of stress. Next slide, please. Lastly, get help. Lassie's getting help. And again, sometimes we all need to recognize when the stress is getting to us, and it's not, we're in the mental health business, and, if we still feel that there's stigma about getting help, then we've got the problem. Next slide. A strengths-based view. Those who feel deeply others' pain. Again, if we didn't feel it, we wouldn't be in the profession we're in. We can use this empathy to help our clients heal. And that is especially true for those with a personal history of trauma or child sexual abuse. That gives people potentially a special ability to understand. And trauma-focused evidence-based treatments are all about transforming trauma into skills and strength. That's the message they have, and we don't want to forget that. Next slide. In summary, exclusively treating or supervising child sexual abuse clients may place any of us at high risk for secondary traumatic stress. And self-care is really up to us. So each of us needs to take responsibility for our own self-care at work. We also need to recognize that most self-care occurs outside of work. And we can transform our secondary traumatic stress into positive strengths. With that, I'm going to turn it over to Susie.
Thank you, Judy. I was asked to speak about what secondary traumatic stress looks like for a clinician who is working in child sexual abuse cases who just happens to be a Hispanic professional. And I think before anything we need to consider what it really means to be a Hispanic. And something that I always share, or that I have shared in several presentations, is that I myself did not become Hispanic until just 5 years ago. And that is usually met with some funny stares. And I can see people wondering, what does she mean? How do you just suddenly become Hispanic a few years ago? And the way that I've always explained that is, I am from South Texas, and I live in a border community where our population is 96.4% Hispanic. So in my community, I am the majority. And I never really thought of myself as being a minority. I'm just like everybody else that is around me. Yet a few years ago, we joined the National Child Traumatic Stress Network and started preparing for our first grantee meeting and started preparing to collaborate with all of these other sites around the United States. And I also started working on a dissertation, and I had a non-Hispanic advisor who just kept stressing how I should focus my research on something related to my culture and the mental health treatment of Hispanics and how there's so little research around that. And he just kept stressing and stressing and stressing how rich this culture is and how fortunate I was to be in a community where I could do the research. So aside from that, we go to our first NCTSN grantee meeting, and I keep hearing this buzz. I was with two colleagues, and we keep hearing this buzz about this Mexican group that has now joined the network. And I remember talking to my colleagues thinking, wow, I wonder who this Mexican group is. And all of a sudden we realized, well, that's us. And that's around the time that I finally took a good look at myself and said, oh my goodness, I'm Hispanic. Isn't that interesting? Prior to that, I would not have identified myself that way because the community that I live in were all Hispanic, so I was just like everyone else. But with these changes came this realization that I am different. I am unique, and I really started to look at what sets me apart. What are some things that I do? What are some things that I believe in? How do I act? How do I behave that is unique to my culture? And I really started to talk to other people and realize, wow, a lot of family celebrations, a lot of things that we do, I get to do because of my culture, because I am Hispanic, and I really learned to embrace that. And that's something that I think we really need to take into consideration when we're working with Hispanic clinicians is, what does it mean to them to be Hispanic? Are they like I was, just completely oblivious to their culture, or are they like I am now, really aware of culture and what it means and how it has shaped us? And I think it's really important. We talk so much about being culturally sensitive, but at the same time, we don't want to be individually insensitive and look at clinicians and think, well, she has a Hispanic surname, so she must believe this, and that, because we're all very, very different. And I think one thing that really comes into play also is our level of acculturation. As I said, as I've really learned to embrace my culture these last few years, I've had a lot of conversations with one particular colleague who immigrated here as a child, and actually was an adolescent when she immigrated here and educated herself, and her level of acculturation is very different from mine. I was born and raised here. I'm something like 5th or 6th generation U.S. citizen, so our acculturation levels are very, very different. So that's something else I think we really need to take into consideration when we're working with Hispanic clinicians, and also look at, regardless of our acculturation level, how do we operate within our culture? What are our beliefs in regards to cultural values? So what is our role in regards to our gender? Do we follow the really traditional gender roles? This is the man's role, this is the woman's role. Or are we more acculturated, more modernized? Do the roles shift a little bit? What is our role within the family as well? What role does our family play in who we are, not just as a person, but as a professional? And something that really, really comes into play with, or two things that really come into play with a lot of the families that we see here, and I've got to just mention that 100% of the families that we treat here are Hispanic, many of them recent immigrants, but in all of the years that I've been doing this work, I have yet to treat a non-Hispanic family. And a couple of things that really come into play often are the issue of fatalismo, which is this belief that anything that happens for a reason, and it is God's will. And also how religion and spirituality ties into that. And this is something that we have seen that really plays a significant role in treatment. How many of our families really turn to spirituality as a means of coping? How many people get through adversity through their faith, through their belief in God and church? And then looking at our role as a clinician, what is my role in treatment? Am I a helper? And if I am a helper, what happens if I can't help everybody? Does that mean that I fail them? And how does that affect how I now view my abilities, my capabilities? Am I doing a good job? And is this just now adding to my stress because I'm seeing myself as not very capable? Next slide, please. It's also very important to look at trauma symptoms. We've mentioned during other presentations how many children are not referred to us because they have experienced a trauma. Rather, they're referred to us because of behavioral problems. And in working with Hispanic families, we often find that they're really not brought in for PTSD. They're not brought in because of traumatic exposure. And they really don't want to be labeled as having post-traumatic stress disorder because that is labeling them with a mental illness, which, of course, translates for many families into craziness. What we start to see is that somatic complaints are a lot more culturally acceptable. And I wrote in a few things in the slide. I wrote in mal de ojo, ataque de nervios, and I put in susto. And I'd like to just take a minute to explain what susto is. Susto is fright sickness, and it is caused by a frightening event. If we experience something frightening, we will develop susto, and the way that susto manifests itself is that we maybe are not able to function as we used to because we have a lot of intrusive thoughts. We keep remembering what happened. We can't concentrate at work. We can't concentrate at school because of these recurring images. We close our eyes and we keep reliving what happened. We're not able to sleep at night because of all of these recurring images. We don't want to be around anything or anyone that reminds us of what frightened us. And we're very, very careful. We're always on guard not to go through that frightening event again. And if you listen to all of these signs of susto, they're very, very, very closely similar to the symptoms of post-traumatic stress disorder. However, it's more acceptable sometimes to say the child has susto because this is something culturally acceptable and it is something that can be easily addressed, as opposed to saying a child has been traumatized, a child has PTSD, they need treatment. So what kind of symptoms do our children present with? And what is the view of counseling? What is the view of treatment? Is counseling for children or families who have been through something traumatic? Or do you go to counseling because you're weak? Do you go to counseling because your faith is not very strong and this is why you need help? I talked a little bit in the previous slide about fatalismo. So if what happened was God's will, if God meant for this to happen, or God presented us with this adversity as a means of testing our faith, then does going to counseling imply that we are going against God's will? How can a therapist be effective if they're trying to counter what God intended for our cross to be? So it's really important to look at how does the culture view treatment, but also how does the Hispanic culture view counselors? How can we be effective, and how effective can we be? And I'll go back to the example of susto. Susto is something that in our culture, if you believe in folk healing, can be treated, can be cured in 3 days by engaging in a certain ritual that takes 3 consecutive days. It can be treated, and it can be cured. And you are cured. Literally, you are supposed to be cured of it. So a lot of times it's difficult for some very, very traditional families to understand, well, if we can cure susto in 3 days, how can you say that it takes weeks or months to cure trauma, to cure PTSD? And they'll keep using that word cure. So you've got to look at, do they see us as being effective? And also consider alternative therapies. Is it more acceptable to go to a curandero, who is a folk healer? Is it more acceptable to go to him or her and maybe address the issue by engaging in some kind of ritual? There is something that is commonly used called either a limpia or a barrida, where it's something of a cleansing, where the curandero will cleanse you with certain herbs, certain stones, certain fruits, and this cleanses you of any negative energy. It makes it leave your body. So is it more acceptable to engage in something like that, in some kind of ritual like that, as opposed to going to counseling. And that can sometimes make a clinician feel really ineffective. So it's important to consider all of those things. Next slide, please. We also want to realize that, of course, we do experience secondary traumatic stress because of the work that we do and the stories that we hear. And, of course, some of the stories that we hear are truly, truly horrific. But a lot of our secondary traumatic stress also comes from a lack of support. And I'm not so much talking about organizational support, but how our family, how our social environment supports us. How are we viewed within our culture for what we do? For example, in my family, my own generation, my cousins, they understand what I do. And they oftentimes will refer people that they know who may benefit from our services here. Whereas older family members, my grandmother's generation, for example, don't really understand the work that I do and don't necessarily respect the work that a clinician can do, because counseling is not something that is acceptable. You don't go to counseling, and you also don't become a counselor. So what kind of support are we getting within our family? Do we have a good social support system? And a lot of it, like I said, is cultural. Judy already spoke a little bit about having a caseload that is very trauma-specific. So again, going back to what trauma is, how is it addressed? Do we even talk about it in this culture? And a lot of times when we don't have that support from our own family, when we don't have that social support, it can really lead us to question ourselves. Was this a mistake? Should I have gone into a different field? Am I really doing anybody any good? What am I doing? Am I actually hurting families more because I'm doing exposure therapy and I'm asking them to talk about something that they shouldn't be talking about, something that they maybe should just be talking to their priest about or talking to their family about, not to me because I'm a stranger. So am I hurting them more than I'm helping them? So this lack of support, these negative cultural views of our profession sometimes can really lead us to doubt ourselves, doubt our capabilities, and doubt our decision to even be in this field. Next slide, please. So many times our cultural background, it can influence not only how we experience secondary traumatic stress, but also how we deal with it. Is it okay for us to ask for help? If we ask for help, does that make us weak? How are we going to be perceived then? And this is something that I often hear is, what do you mean the counselor needs counseling? The counselor should be able to keep it together. That's why they're in that field, because they're strong. So if the counselor can't handle it, they must not be a very good counselor. And this is something that I hear often. So is it okay for us to ask for help? And if we do ask for it, where do we go? Will we go to a professional? Or will we take a more cultural approach and go to a family member? And again, we have to consider, do we even have the family support? Or are they going to try to convince us that, you see, you are in the wrong field. This is not for you. You should just leave well enough alone. Don't ask strangers about their personal business. Or are we going to rely on our own faith? Are we going to seek help from a spiritual leader? Are we going to go to our family priest? Or are we ourselves going to go to a curandero who will, again, cleanse us and remove all of that negativity, everything that we've taken from the families that we've worked with, all of that pain that we are feeling for them because we're empathetic? And can a curandero just cleanse us of that? And then we're able to go on and to continue to function. So if we do ask for help, where are we going to get our help? Who are we going to turn to? And next slide, please. There has recently, I've realized, been a really strong push for cultural sensitivity. And there's a lot of research that's out there. There's a lot of information available regarding cultural sensitivity and how important it is to respect the client's cultural background, to consider how culture, what culture means in treatment, how we can integrate that into treatment to make treatment relevant for the families. But there's very little information on how culture affects a counselor's experiences. How does this affect us, how we operate, but also how we internalize our clients' stories and how we deal with it? And there's a couple of different reasons why there's so little research. For one thing, a lot of clinicians don't identify themselves as being Hispanic, either because they just don't identify themselves that way. As I mentioned when I started to speak, if you had asked me 6 years ago if I identified myself as a Hispanic clinician, I would have said, no, I'm just a clinician. Now, I'm really, really in tune with who I am culturally, and now I can very easily and very proudly say, well, yeah, I am a Hispanic clinician. That is who I am. So a lot of people may not identify themselves that way, but also a lot of people may not identify themselves as Hispanic because of bias. Now, again, I'm in a community that's predominantly Hispanic, so I'm okay saying I'm Hispanic. But think of a clinician who's working in a community that is not predominantly Hispanic, and there may be a lot of bias. There may be a lot of prejudice, and even within the culture, there can be a lot of prejudice. And we also want to consider the fact that there are just not a lot of Hispanic clinicians for a couple of different reasons. A lot of Hispanics still live in poverty, so for economic reasons, it may just not be possible to pursue a higher education. And also, again, social reasons. It just may not be acceptable within our family, within our culture, to pursue this type of career because we don't talk about trauma, we don't air our dirty laundry, and we don't seek mental health treatment. We deal with it within the family, or we seek alternative therapies. Next slide, please. So I was really glad when I was asked to be a part of this webinar because I definitely think that secondary traumatic stress is something that we need to pay attention to and not just talk about, but really, really do something about. Something that we really need to engage in, and as those of us that are supervisors really pay attention to the traumatic stress, the secondary traumatic stress that our supervisees are experiencing. But while there have been several trainings and conferences and presentations and a lot of publications addressing secondary traumatic stress, are any of them being sensitive to the needs of Hispanic clinicians? So I was really, really excited when I was asked to be part of this because I thought, great, I can hopefully expose a few people to what it means to be a clinician when you are a Hispanic as well. So that's something that I think we need to start doing, is not just look at, okay, what is vicarious trauma, how is it affecting our clinicians, but how is their culture either helping that or making it worse for them? Next slide, please. And in regards to child sexual abuse, that is still one of the least talked about subjects in our culture. There is still a huge stigma attached to it. It's still very taboo. And it is something that we are just not supposed to talk about. And that can make it very, very difficult for a clinician to encourage a family to talk about something that they should not be talking about, that we should not be asking about. And it makes it hard when you're doing exposure therapy, when you're doing something like trauma-focused CBT, and you're talking about gradual exposure, yet your culture is telling you, no, don't expose them to this, don't push, don't make them talk about it, it's none of your business. I'll tell you, we had a mother call in a few weeks ago asking for help for her daughter who had been sexually abused. And not an hour later, grandmother calls in and says, I don't know what was wrong with my daughter. I don't know why she called and asked for help from you people. This is a personal issue. It's a family issue. We will deal with it in the family, and we will make her forget about it. She's not going to talk about it. Thank you, but no thank you. So how do you address these kind of cases that you're not supposed to talk about? How do you internalize them? And then when they really start to hit close to home, and you really empathize, and you really start to feel some of the traumatic stress yourself, what do you do about it? Who do you go to then? And I also talked a couple of slides back about bias within our own culture, and there is a lot of that as well. You can have two Hispanic individuals. You have a lighter-skinned one and you have a darker-skinned one. The lighter-skinned one is going to be seen as in a more favorable light. So even within our culture, there is still a lot of bias that a lot of us are still trying to work through. And again, when we go into a community that's not predominantly Hispanic, we do stick out like sore thumbs. So dealing with the trauma that our children are experiencing, dealing with the stories that they are sharing with us, and then dealing with the biases that we are having to experience, dealing with a lack of social support, dealing with a lack of family support in some cases, and with our own self-doubt can really, really be detrimental to the work that we're doing. And I'm going to go ahead and pass it on to Leslie now so that she can talk more specifically about secondary traumatic stress.
Thank you, Susanna. I think what you're talking about is so critically important for us to be aware of. I was recently doing some training with a group of interns, and it was a small group. There were only 6 of them. But our agency, one of our central sites, is in the middle of Koreatown in Los Angeles. And in this group, there was a Korean-American woman. There was a East Indian woman of Muslim faith. There was a couple of Latina women. There was an African-American woman. And we were having such a rich discussion just about these kinds of things because as an agency, when you're trying to address secondary traumatic stress and how do you provide support for your workers, and one of the things that we know is that one of the first steps is to provide training on it. And this is such an important issue to look at those cultural perspectives because when you have that many people in the room, not only are you looking at the cultural interface between those clinicians and their clients, but also about their own personal experience and how it impacts not only their work, but their experience of secondary traumatic stress. And it makes it a very complex and also rich discussion and challenging. And I think it was very helpful for me to hear what you shared because I think you very profoundly looked at it from that particular cultural lens and I think gave us a good look at how important it is to consider those elements when you're looking at secondary traumatic stress, not only just looking at treatment. I want to focus more on organizational management of vicarious trauma and burnout. One of the things that I wanted to start with is that when you listen to the story of another's pain, victimization, or horrific stories, it's normal to experience some similar distress reaction as the help seeker. I can't emphasize enough that sense of this being normal. Even if we are doing a great job and most of the time we're very happy with our work, there are going to be certain times where we're vulnerable to specific stories, to certain interactions with our clients that impact us in a way that challenge us. And so in understanding that, if you look at it from an organizational position, this is a risk. It's an actual occupational hazard in providing care for particularly children who've been traumatized. I think this is not a lens that we typically use in looking at treatment in organizations. And so it then falls out of the radar of looking at risk management, workforce development, and some of those other things that we typically look at as organizations. So one of the goals of the Secondary Traumatic Stress Collaborative Committee is to really expand that lens to some degree, to come to a place of really acknowledging that it's likely to be experienced in some way by providers who work with children, that is some kind of trauma or stress. Now, I think that's very different. I think we also fall at risk of seeing it as a disorder. Secondary traumatic stress is not a diagnosis. It's a response to being exposed to distressing stories. And in some ways, it might mirror some of the traumatic stress symptoms that we see in our clients. But it's not that we are out there trying to identify that we have PTSD. It's helping us understand how do we implement self-care and policy and strategies for prevention on the one hand, and also for intervention when our staff are experiencing stress. I wanted to talk a little bit about some of the emerging evidence that's documenting this occupational risk. Judy Sprang, who is at the University of Kentucky, is the co-chair of the Secondary Traumatic Stress Collaborative Group, and she's recently done some studies, some large surveys on compassion fatigue, burnout, and compassion satisfaction. One of the studies she did with over 1,500 surveys showed that almost half of those people scored very high scores on secondary traumatic stress. So we are really seeing that a lot of our workers out in the field are experiencing this. And hopefully we'll be continuing to do more research and more studies to begin to document this. Some of the other things that she found, though, that compassion fatigue and compassion satisfaction were impacted by training. So those people who took the survey who actually had training on vicarious trauma and prevention or self-care actually had higher scores on compassion satisfaction and reduced scores on compassion fatigue and secondary traumatic stress. The other thing that was significant in terms of assessing on these surveys was that people who had training in evidence-based practices also had significantly lower scores on their secondary traumatic stress symptoms. So we are seeing a trend that training is showing to be an important protective factor in reducing secondary traumatic stress. But there's a little bit of a double-edged sword there, as Judy had said earlier. As we begin to implement more of these evidence-based practices, and we're seeing this more and more in our field, we are giving our practitioners more and more cases. And so we are also seeing in the literature that having a higher caseload, particularly of trauma cases, is going to increase your risk. So from a policy and an organizational level, how do we balance that? What can we do to implement strategies to promote self-care and prevention while at the same time meeting our needs of productivity and implementing evidence-based models and all of those issues? So finding that balance is really challenging. Next slide, please. One of the things that is critical at an organizational level to begin to address this is to do some assessment. And I think that we've spoken about this and addressed it earlier from a personal level. One of the ways individually that we can help protect ourselves is have some way to do a self-check. I think many of us that come to this field because we care and we want to help others. That alone puts us at risk of experiencing secondary trauma, but not really knowing it. Because not only are we not as self-aware, but we also have cultural factors, we have work environmental factors that say things like, well, if you're really good, you'll just tough it out. It's a sign of weakness if you're showing that you're getting burnt out. Or it's just your job. This is part of your job. If you were good at doing your job, you wouldn't be having these problems. Well, we know that doesn't help us. It doesn't help us get the care that we need, and it doesn't help us learn how to do those self-check activities to be able to know when we need some kind of help. So this kind of information is obviously very important to us personally, but it also should inform clinical supervision, administrators, and policymakers to begin to think about how they can impact finding some kind of balance. Assessment at an individual level is critical, but also at an organizational level and even in supervision. How many supervisors receive any kind of training about how to assess with their supervisees whether they have secondary traumatic stress? Are our supervisors receiving any kind of training not only on how to address their own experiences, but how to address or assess the experiences of their staff? So one of the things that is important to look at, culture culturally within an organization is, what are the barriers to staff self-care? How can you create that culture of support and resilience? And I think one of the things that Judy mentioned earlier is that if you can focus on what your strengths are and build on those, right away you're above and beyond where you can start up from. So if you're acknowledging your strengths and working from that as opposed to focusing on what's wrong, right away you're going to be doing better, you're going to be finding solutions. I think that it is really critical for us as a field and as clinicians to take responsibility for our own self-care and to inform our supervisors and our organizations about our needs. But I think it needs to come from the top down as well, and we need to all come together and collaborate to find solutions. So part of that can come as an organization from doing some kind of formal assessment. This could be attached to formalized training, or it can be attached to launching some kind of peer supervision work. There's a lot of ways to do it, and you can do very simple kinds of assessment, or you can do formal standardized tests. One of the things that we're doing as a network currently is inquiring what agencies are doing around the country to address this, and if they have models in place, what are those? So that we can begin as a field to come up with models of intervention and prevention in our organizations. Organizational support can come in many different venues. Training is really critical. I know that for new clinicians, a lot of them have had no training on secondary traumatic stress. They may not even know what the signs are. They may be afraid of the stigma associated with it, that it means maybe that they're not doing a good job. One of the things that was mentioned earlier is you might have you don't really feel that you can be vulnerable enough to share some of your experiences because your supervisor is in a position to evaluate you, and maybe you're concerned about your performance already. So are there other avenues that you can explore to get the support that you need? It's important to identify those so that you can take responsibility for knowing how and where to get the care that you need. Larger training in the organization is very critical too. So not only do you need to train individuals, but are you training supervisors? Are you putting information out into the professional community that this is an issue that is important and needs to be addressed, not only in your organization, but also at a larger policy level? Next slide, please. So what can we do for supervisors? To take care of ourselves and our staff properly, we must understand the challenges. If we are not providing any kind of training or support for our supervisors, how are we going to be able to begin to do that? Understanding what the impact of what we do is very important. If we have supervisors who are overseeing 100 or more cases, are we even considering the level of stress that they're experiencing? Are we considering how to address that and also how to help them support their staff in that way? Is that the best way to do that? Perhaps in larger agencies where caseloads are so big, it might be valuable to see if it's possible to create some kind of peer supervision group, particularly for more senior staff who are no longer required to have regular supervision. Sometimes this debriefing kind of atmosphere can create a safe place where colleagues can come together on a regular basis and just share their experience and be supported in that group setting. I know that many agencies utilize external support for their staff. So they may bring in another organization that will provide some kind of counseling or support in facilitating these kinds of groups in their agency. This creates a neutral space again so that the staff are not threatened by the potential risk of sharing some of these experiences with a supervisor that may be evaluating them. I recently was talking to a colleague of mine who works in the military, and one of the other things that we know is very helpful is creating a self-care plan for activities that you can do outside of work for prevention and intervention. And they were doing this on a large scale, working on self-care and coaching their various clinicians about how to do this, and they were finding that it really wasn't working. And they realized that even though these clinicians had these great plans, they just weren't doing them. And so they decided to change their system a little bit, and they created a buddy system, which is a very common practice and has been very successful. But But instead of having a buddy system where you're just supporting each other, they actually were holding the buddies responsible for the other person. So you were responsible for your buddy's implementation of their self-care plan. And their success rate went very high because for some reason it seems to be easier to help somebody else even implement their self-care. So there's a lot of different ways that you can go at this from an organizational perspective without expending a lot of resources to begin to change this culture in your organization and to be able to bring in more focus on the whole organizational system to support our clinicians instead of what I think more recently has been a focus on how are we implementing these evidence-based practices? How are we going to be able to train all of our staff and make sure that they're practicing these models with fidelity? I think there's been so much emphasis on that area in the past few years that we've lost sight a bit of the needs of our practitioners in that process. How do we know as individuals and supervisors when we need support? Next slide, please. There's all kinds of self-assessments out there, but this is one that I use frequently. Earlier in this presentation, where we were talking about some of the ways that secondary traumatic stress can influence us and impact us personally. One of the things that supervisors can do in asking themselves and also their supervisees is how has working with traumatized kids affect you in these many different areas? So how does it affect your beliefs about the world? How does it affect your spiritual beliefs? I think when we're talking about culture and spirituality, some people do look to spirituality for support. That many times our spiritual beliefs, we have kind of this, what's referred to as negative religious coping, where our religion is actually not supporting us, and our religion is contributing to our sense of feeling bad about ourselves. So it's important to look at that both ways. Our sense of self, our groundedness, our emotional stability, are we just a little bit more sensitive? Are we a bit more hyper-aroused? Do we have a little bit more difficulty listening to these stories? Or perhaps it's going in the other direction and we're becoming numb. And again, when we're looking at some of these things, we have an ethical responsibility when we're providing services to be the best that we can be. If we're beginning to experience a sense of numbness because we're having a difficult time managing the stories and the stress of what we're hearing, it's critical. I mean, it's ethically vital for us to seek the support that we need to be able to find our balance so that we can really do the best work that we can. Sense of personal and family safety, I think Judy talked about this already. Issues around trust, issues around judgment. Very often when we do this kind of work, again, it's sort of a double-edged sword. On the one hand, we can be much more critical and judgmental about people, but on the other hand, we can be really inspired by the stories and the courage and the strength that some of our families bring. So when you look at secondary traumatic stress, one of the things that I always like to bring to light as well is this idea of compassion satisfaction, or some of the positive feelings we experience also in doing this work. And can we come from that strength-based perspective, both personally in supervision and organizationally, to work from that and build from that? A sense of control. I think one of the most difficult things to grapple with is a sense of helplessness within our organizations, within our systems, within our cultures, particularly as we move towards these evidence-based models, which very often, when you're dealing with a very complex family in a challenging system, is it enough? I think so often we feel like we're not able to do enough. Ability to be alone or be with others. Sometimes, I know, when you go into a social setting and somebody asks you what you do and you start talking about your work and they sort of move off to the other side of the room, people don't really know often how to talk about this kind of work. It can be uncomfortable. So sometimes if you're feeling particularly stressed by your work or impacted by secondary traumatic stress, it can be challenging to be with others because you just don't want to tell those stories again. Relationship to your body. I think particularly in working with cases of child sexual abuse, we can have issues related to our body. There are so many different things that can come up, but I think particularly in this field, in this particular area, that can be something that can be challenging. So some of these areas might be topics that you could talk about in supervision, or even you could recommend to your supervisees that they journal about it, or that they consider it, or that they monitor it. So it might not be that you have time to talk about each one of these issues with every single supervisee, but even if you just bring it to their attention and check in with them every now and then and see how they're doing, it could make a world of difference. I was doing actually some training for supervisors recently, and one woman was talking about how she realized that her supervisee was having some trouble, but she didn't really know what was going on. She was having trouble with her performance and getting her work done on time and picking up new cases. And finally, when she brought in this perspective and started asking these kinds of questions, she began to understand that that was the problem. And their whole relationship changed, and this person's work performance really improved dramatically. Next slide, please. So how do you know when this has happened to you? Again, we are a resilient bunch of people. I think we are able to do this work because we are strong. We're able to take in this kind of information and be able to be with people and sit with it in a way that other people are not able to. I think that impacts our own ability to know when it's happening to us. So one of the other questions that could be helpful, and again, this is an exercise that a supervisee can do on their own. They don't necessarily have to share their experience with their supervisor, but it could help them understand and know when it's happening to them. Think of a time when you were hurt in some way by your work. Write down what happened, what your symptoms or your experiences were. How did you notice what was wrong? And then very importantly, what did you do about it? So again, talking about changing a culture, just by asking these few simple questions, you're creating the space for even considering this. And then, okay, as you become more self-aware and identify and notice when these things are happening to you, what do you do about it? That's when having a self-care plan, having some resources, having some knowledge about self-care and what you can do is going to be very helpful. Next slide, please. So again, you can then think about what the most upsetting or disturbing case that you've had. Write down what aspects caused you the most distress and what did you notice. Some key features that we seem to see over and over that are difficult to handle are, one of the things is caring about the client. We care about our clients, that's why we do this work. That's why we do this work. So if we're deeply caring about our work, we're going to be at higher risk for experiencing some secondary traumatic stress. On the other hand, if we become more self-protective and distance ourselves and shut down that caring somewhat, then we run the risk of becoming numb and not being as available or accessible as we would like to be. So finding that balance is really critical, and asking some of these questions can help us identify when we get out of balance. We've talked about feeling helpless. I know many of the colleagues and trainees that I work with experience that frequently. Either it's helplessness with the system or a family that just seems to be stuck in an ongoing pattern that they're not able to shake out of. It's very easy to feel helpless, and I think very often we suffer with that in isolation. So by asking some of these questions, we can make it culturally acceptable within our organizations to explore some of these ideas. Getting triggered by the client story or behavior. Certainly if we are in some way managing or dealing with our own trauma history while we're working with our clients, whatever those triggers are, if we aren't very aware of them and what we need to do to manage those, we are going to be at risk of having more secondary traumatic stress and also not being at our best when we're serving our clients. So by becoming aware of some of these features, when we think about some of our upsetting or most disturbing cases, it can help us identify where we get triggered and then what we need to do to take care of ourselves. And so even by asking a few simple questions as a supervisor or choosing in your organizations to train your staff around some of these ideas, right away you're creating a culture where it's okay, where self-care is acceptable and promoted, and where your staff have the opportunity to get creative, to bring their ideas to the table, and to work collaboratively with administration to change the way that we address these issues in our organizations. Next slide, please. So what are some of the barriers to self-care that we've already talked about many of these already? Accountability is really key. I certainly know in our organization here at Children's Institute, we absolutely have to focus on issues related to productivity, making sure that we are getting all of our documentation done. This is a critical aspect of running a business. But when we talk about accountability and we focus to risk management and the occupational hazard of secondary traumatic stress, where are we being accountable to supporting our staff and developing our staff in their ability to address these issues on our own? I think this is a key barrier that as organizations and in our policies, we don't really have that sense of risk management or accountability where we are taking some responsibility for wanting to partner with our staff in addressing these issues. How is self-care integrated into supervision, into programs, and into policy? We have gotten so good. We have moved so far along in the field of implementing evidence-based practices for trauma. It's amazing to me in the last 10 years how much progress we've made. I think we have some work to do to bring up to speed our interventions and our policies around addressing secondary traumatic stress in our providers. What kind of training do you provide for your supervisors and managers that help them to manage stress and secondary trauma for themselves and for their staff? I know that I actually personally do a lot of training both locally and around the country, and I think that many organizations just aren't aware of the resources. They don't really know where to turn. So one of the goals of the Secondary Traumatic Stress Collaborative Group is to begin to create some of these resources, which is one of the goals of this webinar and further webinars that are going to be coming in the future. So as organizations or as supervisors, even individually, where can you go to get some resources? So it's important to develop a library and a list of resources. If you Google it, there's all kinds of things online that can be supportive for beginning to develop creative ways for addressing this. And I think we've already talked about taking responsibility individually for understanding self-care and what those practices are. I think as supervisors and administrators, we can play a part and take a role in that as well. And we can identify our own resources that we can begin to bring into our particular roles within our organizations to change this culture. Are there policies in place to respond to staff who have negative experiences in the field when they're directly exposed to dangerous or frightening events? So this is another level of experience and exposure that we have to be considering, because many of our clinicians, as they're doing more field work, are directly exposed to trauma. They're in dangerous neighborhoods, and they may either witness or hear or experience something else that's happening to them. So do we have policies in place to address these different levels of occupational hazard around secondary traumatic stress, around direct exposure, and even about helping our staff understand the impact of their own traumatic experiences and how that relates to their work? Next slide. So where do we go from here? What we've talked about already: assess your staff, assess yourself, practice self-care strategies, not only individually, but at every level of the organization. How can you bring in some of these ideas to begin to change that culture? Develop a plan and use it, even if that means if you have to find a best friend to help you implement it. Find a buddy, professional peer support. Actively build prevention and self-care into your policies and into your own lifestyle. Remember that vicarious trauma and burnout are occupational hazards. These are a normal part of doing this kind of work. We must plan accordingly, not only as individuals, but as organizations. Just as in other professions, there is a risk involved in doing this work. We must practice safety and self-care. Next slide. Over to you, Kimberly.
All right. Well, thank you very much, all of you, for that wonderful presentation. We now move to the question and answer session of this event. If you could please submit your questions by clicking on the bubble icon on the upper left corner of your screen, or you can send a question to question@nctsn.org. We have had some questions submitted.
The first question says, any thoughts on secondary traumatic stress for male therapists who have been working with sexually abused children? As a male therapist, I have a few male clients who have been sexually abused, and I was wondering if there are any research information on STS with male therapists in particular. Any of you ladies have that information?
I don't know of any.
I don't know of anything specific for males.
I don't know anything specific to males, although in the studies that Jenny Sprang did with her colleagues in Kentucky, males were certainly included in that study, but they weren't specifically looked at.
Okay. Do you have any suggestions for this therapist as to how to handle working with males that have experienced sexual abuse?
There are a lot of materials, resources for working with males. For example, it happens to boys too, and so there are a wealth of materials for working with boys. And I think just normalizing it, validating, that it's difficult and addressing the concerns the boys may have in that regard. But I think it's wonderful to have a male therapist because, most therapists are female, so I think it's really helpful that the male therapist is in the field and providing a positive model for recovery and coping. So he's lucky to have you.
Wonderful. Thank you so much. The next question says, I'm a therapist and sexual abuse survivor that has never told any clients my story about my personal history. To me, this is just a boundary that I do not want to cross in therapy. However, my supervisor says that if I were not experiencing vicarious trauma by my client's story, then I'd be willing to share my personal history with them. Is that true? Any of you ladies want to answer that?
My opinion... Oh, go ahead.
No.
My opinion is that everybody has the right to set their own personal boundaries about whether they share personal information, and that is not a sign of secondary traumatic stress. That if you have a personal history of trauma or sexual abuse, you have the right to make the decision in a specific case or generally that you do not want to share it or that you don't think it's appropriate, and that is not necessarily a sign of secondary traumatic stress.
I would second that. I agree that it is certainly the individual's choice whether they want to share that or not, and in some ways it can actually show a sign of having good boundaries and all the things that show good clinical judgment. So I would not say that that is a sign of secondary traumatic stress.
Do you guys have any suggestions for this listener as to how she could broach this subject with the supervisor?
I'll jump in. I would say one of the things that I might recommend is secondary traumatic stress has many kinds of symptoms, many of which we've talked about, and others certainly that you can get resources and learn about. It's not just one thing. So one of the ways that I might address it with a supervisor is to say, well, there's many other areas and signs of this, and I'm not experiencing any of those. Or if you are experiencing some of those, perhaps shift the conversation to talk about some of those other areas where maybe you are experiencing them, or to demonstrate that you really feel very balanced and that that's not particularly an issue, and just choose to hold that boundary.
Wonderful. Thank you. The next question says, I'm dealing with a case of sexual torture. I've treated sexual abuse cases before, but nothing like this. I'm pretty sure I have PTSD. I'm afraid if I tell my supervisor, I will have no choice but to leave my job, which I actually love. Do I have any other options?
I would say there's certainly many other options. I don't know that you necessarily are required to share that information or those experiences with your supervisor if you don't feel safe doing that, but I would recommend that you seek some outside support.
Anyone else have any suggestions?
I agree with Leslie. It does concern me that there would be a concern over possibly losing a job because of PTSD on the part of the clinician. But yes, I think, first of all, I commend you for recognizing those symptoms in yourself and realizing that this really is affecting you. I think that's a really big step, and I would definitely encourage you to seek some kind of outside support, whether it be from another clinician or any support system that you have.
Wonderful. Thank you. Question says, I'm supervising a case in which a teen was severely ritualistically abused as a part of a religious ceremony. The teen supposedly agreed to the sexual activity, which she may have been drugged, but this has not yet been proven. I have been having trouble helping the therapist contain her anger since I feel the same anger myself. How can we tell whether this is normal anger or vicarious trauma? Is it normal and healthy to feel anger, even extreme anger, when children are so viciously maltreated and the system does not adequately protect them? Good question.
Well, my response would be yes. To a degree, yes, it is normal for us to be angry and upset when these terrible things happen to kids. But, the question is, at a certain point, is it getting in the way and is it helpful? And, can we transform that anger into action that can be, constructive? Because at a certain point, is it destructive not only, for our clients, but also for ourselves? So when we're getting angry to the point where we feel like throwing something or yelling at people or it's keeping us up at night, is that helpful to our client? It's certainly not helpful to us. How is it helpful to our client? Or to the therapist? The therapist comes in crying and you say, yeah, I know, I want to kill the so-and-sos too. That may be validating to a point, but is that helpful to the therapist? Is that helpful to the client? Because justice is probably not going to be done in this case. So how can we transform that feeling into some positive action? And, it is possible to transform that into some determination to, we're going to get this kid through it, and we're going to get ourselves through it, and we're going to not let this happen. We're going to help 10 more kids get through it. That's how you can sort of transform it into something positive. Because there's not much you can do about the people who did it to her, apparently. We have to find a way to turn it into something positive and help this kid and protect her in the future and help her move forward.
Thank you. And the last question. After hearing this presentation, I see that we need to develop some policy and resources for our staff, but where do we start?
I'll take that one. This is Leslie. I think there are so many resources out there. I would start small. There are a lot of small things that you can do to begin to affect change. And as I was speaking about earlier, think about just shifting the culture and think about collaborating with the staff, with the supervisors, with the administrators, and have people come together just to begin to talk about the information. There's research out there. The Charles Figley Institute has a lot of information about secondary traumatic stress and self-care and how to implement those practices in organizations. There's a wonderful book called Trauma Stewardship that addresses it somewhere by Laura von der Noot-Lipsky. And there are many other resources that I think if you begin to explore it and you take small steps, that those changes will occur over time.
Thank you very much. This concludes today's presentation. I would like to thank Drs. Judith Cohen, Susana Rivera, and Leslie Ross for speaking today. I would also like to thank each of you for joining us. Remember to complete the post-presentation evaluation survey in the Learning Center. Thank you again for joining us today.